I'm Mark Henick, and this is Modern Minds Rewind. Here's my conversation with Dr. Mark Horowitz. This episode is going to be dealing with medication. Nothing that you hear today should be understood as medical advice. If you're considering adding, changing, or stopping any medication, please discuss it with your healthcare provider. So we're talking about deprescribing and specifically in psychiatry and mental health. I'm going to get you to unpack that for us as we go along. But first, I want to think about just how things are right now. You know, deprescribing assumes prescribing. Antidepressants are among the most widely prescribed medications in the world, as are other agents in this space. So what's your perception right now on treatment as usual? How does treatment of mental illness usually go?
Mental illness is obviously a very wide category that stretches from common anxiety and depression all the way to what people see as more serious mental illness like schizophrenia or bipolar disorder. In general, the treatment of all mental health conditions is currently very medicalized, which is it's a process of fitting someone's symptoms to a diagnosis and then giving them the appropriate medications. Of course, therapy and other non-medication treatments are given alongside that, but it's become predominantly a medicalized field, a field where medications are used primarily. When you understand, for example, anxiety and depression occurs in about 70% of people up until the age of 45. It's a very common condition. And so rather than seeing it as a medical illness that requires specific medication, it might be better seen as a fairly normal part of people's lives and treated in a less medicalized way. But that aside, it is now treated in a highly medicalized way. In the US, 1 in 4 people are on an antidepressant. About 1 in 6 or 7 are on a benzodiazepine or sleeping tablet. In Europe and in England, 1 in 4 people are on some sort of psychiatric medication. So psychiatric medications are now prescribed very widely, and they're increasing every year.
Now, that biomedical model of mental illness, it's, as you mentioned, certainly the prevailing one in America and elsewhere. It's this materialist or physicalist view that problems of the mind are problems of the body. It kind of collapses the difference between them. And I think it's probably this determinism too, maybe, not to get too philosophical, that problems can and should be defined and fixed. So I'd like to challenge you maybe a little bit, but do you think there's any benefits of that medical lens on mental illness? We'll get to the drawbacks, but do you think that there's been any benefits?
Look, it's a huge area of debate. I mean, I'm not suggesting dualism or that the mind and the brain have nothing to do with one another. I think it's a sort of truism to say that everything that happens in the mind occurs in the brain. I guess the contention in the field is that the best level at which to understand things? So, one approach to understanding depressed mood would be to look in the brain at what part of the brain is more active during depressed mood. And that is where a lot of money has been put to look at what are the neural basis of depressed mood. Another way to think about it would be what are the circumstances in someone's life that have led them to be hopeless, demoralized, or suicidal. And that is a very different approach. To some degree, all approaches may have some validity, but the last 50 years of research in the field of anxiety and depression has produced no concrete findings that have helped us to forward how we treat anxiety and depression. And so one perspective would be that we're looking in the wrong place. An analogy, hackneyed as it might be, could be that in trying to fix a software issue, we're looking at the hardware. So that if someone has an issue with Microsoft Word, if someone came along and opened up the back of your computer to start solving the circuits, you might think that was a bit peculiar. That is currently what we're doing in the field of psychiatry. I think we're mistaking things in people's minds and in their lives for what is going on in the brain.
So, I mean, beyond the sort of academic debate there, what are the real world implications or drawbacks, do you think, as it affects people who are suffering and the patients of that kind of model?
So I think it can be unnecessarily pathologizing, and I think it can be stigmatizing, and I think it can lead to worse outcomes. So it's often said that giving people biological explanations of what's going on with their emotions is destigmatizing. That if you tell people there's something wrong with their brain, it's not their fault, that you're making life easier for them. But there's another side to that, because if you tell somebody that the reason why they're feeling demoralized, hopeless, or suicidal is because there's something wrong with their brain that we haven't quite worked out yet, but research may one day work it out. You're telling them that they essentially have a broken brain of some sort. It is often experienced as a relief in the short-term diagnoses, and in the long term, it can become a sort of self-fulfilling prophecy because people are less inclined to rely on themselves or less inclined to think they can make changes that will affect their health because they're told that there is something organically wrong with them. And that implies that medical interventions are the most sensible thing. So I think that telling people that they've got a condition like major depressive disorder or generalized anxiety disorder, rather than explaining to them that they're demoralized because various social relationships in their life are unfulfilling or they're under certain stresses, can in the long term lead to worse outcomes and people internalizing a negative and broken image of themselves. I see all the time in clinical practice.
Yeah, I mean, billions of dollars of research have been spent, especially, and it seems like it's increasing in recent years. Has been spent on basic research in the physiology and the neuroscience of mental illness, as well as in the social sciences and on social determinants of mental health. But I heard you say just a minute ago that we haven't made a whole lot of headway. We haven't produced a lot from that research. Can you talk more about that?
So you don't need to take my word for it. You could take the word of Thomas Insel, who was the head of the National Institute for Mental Health Research in America, who said that after spending tens of billions of dollars on research into mental illness, they hadn't moved the dial at all in helping patients. They, in his words, had produced some cool science on genetics and imaging, but nothing of practical significance to patients on the ground. And I think that is, in general, the sum total of the neuroscience research that's occurred for the last few decades. It hasn't had any practical improvement in the lives of people suffering from conditions. And I think that comes down to that, what I would see as a fundamental category error, mistaking issues in the mind and people's lives from issues in their brains. There's an incredibly clear relationship between stresses in people's lives, uh, poverty, relationship discord, physical illness, and the rates of depression and anxiety. So it is very clear from research that it's conditions in people's lives that lead to feeling depressed and demoralized and suicidal. And I think it makes the most sense to deal with those conditions, hard as that might be, rather than looking further for some corner of the brain that we can tweak with a medication or with electricity to fix issues in people's lives.
Mm. There's been such an increase in mental health awareness and campaigns, celebrities, governments are talking, just in the last probably 10 years or so, mental health has reached sort of a bubble of sorts in terms of awareness. But I've also noticed that there's a certain central dogma of so many of these campaigns and conversations, which comes back to what we're talking about, that the idea that mental illnesses are brain illnesses, that depression is just like cancer, that collapsing of the difference. And I think the goal is probably a noble one. It's to lend legitimacy to mental health by hitching it to something that's seen as more legitimate, physical health. Is that particularly helpful, though, or could that be harming people who are struggling to try to reduce it that way?
I agree with you. I think a lot of this comes from probably good intentions, that it will lead to less stigma for patients if you tell them it's a brain condition, it's not their fault. I also think it stems a bit from the interests of drug companies who, in convincing us that we have neurochemical problems, makes us more likely to become customers for neurochemical solutions. I think that it can be damaging for people to be told that the very common, often very understandable emotions that they experience are actually illnesses, because one thing it teaches us is to be afraid of our emotions. Um, you know, uh, as I said earlier on, actually, by the age of 45, 86% of people will meet criteria for mental illness. 70% of people will meet criteria for anxiety and depressive conditions. So these are very common conditions in life. When we are overwhelmed by demands in life, we become depressed. When we feel very insecure about the future, we become anxious. So these are very common conditions. I just think of a report in England at the end of last year saying that there was a spike in mental health conditions amongst young people, and it was associated with poverty and bullying. And the response to that was for there to be more research into what is causing mental illness and how we can best treat it, which I sort of think of as an absurd response. That can only exist in a society that's sort of been seized by neuromania, where the brain and technology offers so much promise to understanding these things. Because obviously, you would respond to that by saying poverty and bullying causing people to become depressed. We need to address bullying, not to turn to understanding the brains of people who are depressed in those circumstances. We would all become depressed in circumstances of oppression. And so I think that there has been this reductive focus on the brain and a look to technology for explaining what is going on has turned us away from the more intuitive, obvious, humanistic explanations for what is going on. And I think it has distracted us from what the real solutions are. And I think it's very important.
Redirecting resources as well, right? I mean, if there's a bullying problem, and as we know, hard things are hard. Hard things are supposed to be hard. Of course, you would react in an adaptive way to that. So then to fund something that isn't focused on the core problem seems like a misdirection of resources.
I agree. There's been a huge expenditure in the Western world into research on genetics and neuroscience to make sense of psychiatry, and it's all very interesting. And I've did my PhD in that topic, and understand why people are so fascinated by it, as I was, because there's this promise that we could understand what is under the hood and causing emotional problems. It's very appealing. But I think that we have spent large amounts of money that hasn't returned any of the people on the ground. Sometimes I've had people say to me that it's utopic to think about solving issues like poverty and bullying, which are widespread. But I think unless we are honest about what is causing the problems that we're experiencing, we have no hope of solving them. So it may well be that inequality and bullying are very difficult issues to manage. But if we pretend that the issues exist in the amygdala and hippocampus and not in schools and our societies, then I think we are being directed towards solutions that are not really the ones that are going to have the most benefit.
Let's drill back to the medication piece specifically, because I imagine people who are listening or watching might be thinking, well, what's this have to do with deprescribing? But I think it's important background cultural context of why somebody would want to deprescribe in the first place, and how we got to the place where maybe they're prescribed. So let's talk a little bit first about the efficacy of medications in psychiatry in general. It seems like we have more antidepressant prescriptions, for example, than ever before, but people are also more depressed than ever before. The numbers seem to be going up, not down. Can you help us make sense of that?
Yeah, so it's a great point. So when you think about deprescribing, so one, you've got it on the background of what I've just outlined, which is several decades where the medical model of mental health conditions has been predominant. It's led to widespread prescribing. Many people would argue gross overprescribing, where now 1 in 4 or more people in Western countries are on a psychiatric drug. And so deprescribing, which didn't come from psychiatry in the first place, it came actually from geriatric medicine, is the idea of rationalizing overprescribing, because medications can, in some cases, cause more harm than good. and deprescribing is simplifying people's medication regimes in order to address those harms. When it comes to antidepressants in particular, you've made a very astute observation that other people have also made, which is if antidepressants were very effective for anxiety and depression, then how come we have rising rates of anxiety and depression when an effective drug like insulin was introduced into medical practice? Amputation of diabetic limbs went down. It would be very peculiar if alongside the introduction of an effective medication, amputations of diabetic limbs went up. And so you're right to ask the question, are these drugs effective? And the science on this issue is in my view, quite clear. There have been about 1,000 studies on antidepressant effectiveness where they compare an antidepressant to a sugar tablet. In these studies, they show that antidepressants are better than sugar tablets by about 2 points on a 52-point depression scale. A very, very small difference. There are a few reasons why even that difference is probably exaggerated. People who are given antidepressants are unblinded in these studies. They know that they're on a medication because of the side effects. When people know they're on a medication, it leads to expectation effects that they'll get better. That may make people on medication show improvements that are not due to the medication, but due to their thoughts about the medication. The studies are extremely short-term. 97% of these studies are conducted by the drug companies that are selling the drugs. They go for normally 6 to 12 weeks. We know that people in America, most of them on antidepressants are taking them for more than 5 years. In England and Europe, it's more than 2 years. We know that medications tend to wear off over time, what's called tolerance. And so these small effects, if they are real at 6 weeks, are very likely to wear off over time. We know that's very true, particularly for drugs that cause withdrawal symptoms. And antidepressants are becoming increasingly recognized to be cause withdrawal symptoms in lots of people. There's also an issue with publication bias when it comes to antidepressants. We know that most trials are not published. Drug companies are not compelled to publish all the trials that they conduct. When you look at trials that haven't been published, most of them are negative. That is, they show no difference between sugar pills and antidepressants. So there's a wide variety of reasons to think that antidepressants are not very effective. And even the biggest booster of antidepressants will admit they have small effects. But there's now an increasing group of psychiatrists and researchers who think they have no significant difference from from sugar tablets in terms of having a clinically important difference. So, that's one concept probably to get across, which is, for example, if you show that a diet pill is better than a placebo, but it only causes you to lose 50 grams of weight, it's not thought to be a clinically important difference. And that is probably true for antidepressants before we get into the whole host of side effects or adverse effects that the drugs can cause.
Well, I mean, you mentioned that there's more than 1,000 studies. You talked about how underwhelming the evidence is, the methodological issue certainly, but if you this is never a good guide, but if you turn to the conversation on social media, it seems like there's still a stigma against leveling this kind of legitimate scientific criticism against the medical model, against treatment as usual. You get accused of being anti-psychiatrist or a Scientologist or even anti-science. You get accused of pill shaming, all this stuff. What do you make of that social aspect of this conversation? Why does that happen if the evidence is seemingly so clear?
You're right. Discussion about psychiatric medications becomes very, very emotive very quickly. It's very hard to have a rational discussion about it. I think this is for a variety of reasons. Number one, started with drug companies and the academics that work with them in trying to discredit critics of their products. They would use this slur of being a Scientologist or an anti-psychiatrist, which is a way to distract from a discussion of the benefits and harms of medications, which is a completely normal part of medical and scientific work. That's what doctors and medical researchers do in every specialty of medicine. Is this treatment more harmful or more beneficial than another treatment? It's a way of silencing critics. It used to be done. It's very reminiscent of what has been done in the climate change space, where people who would point out the effects of fossil fuels on climate change, used to be dismissed as communists or anti-corporate actors, rather than considering the scientific facts they were putting forward. It's a similar kind of approach taken by drug companies and their supporters. It's also become mixed up in identity politics, where many people have been told they have a mental illness. They've incorporated that into their identity. I understand that very well because I've been exactly in that position. I've done the same thing. It's a way that people make sense of their lives and make sense of the distress they've been through. And criticizing medication is tied into criticizing the legitimacy of people's suffering, which I think is a very false connection. It's been called the false brain or blame dichotomy. If you're criticizing the effectiveness of medication, you're thought to be criticizing the reality of people's mental health condition, and therefore blaming them for being weak or something else discriminatory. Now, I would argue that that's not really what's happening here. Now, I think people respond to depression and stress in their environment in an understandable way that requires support and merits systems. And criticizing medication, looking at its harms and its benefits, is not an ideological process seeking to stigmatize people, but doing something that's a very core part of being a doctor or a scientist, which is looking at the evidence on either side. And it's very unfortunate it's become so emotive a topic, and people cannot discuss it, work out what is best for people.
Can you maybe tell us a bit about some of the motivations that somebody might want to deprescribe and how they can go about having that conversation with their doctor?
So the reasons why people would like to stop medication in surveys and in patients that I've seen, the number one reason is people want their emotions back. They feel that being on antidepressants causes numbing of their emotions. That is, both negative and positive emotions are squashed. They're less in intensity. Some people experience that effect of antidepressants as being very relieving in the short term. They often start medications, in the throes of panic or anxiety or depression, and to have the emotions turned down from a 9 to a 3 is experienced as a relief. In the long term, it has consequences for people because we don't have medications that are so brilliant. They just target negative thoughts. They target all emotions that we have. And so people lose interest in life, excitement. It affects their relationships. And so that's the number one reason people want to come off these medications. Other reasons are different side effects or adverse effects of these drugs, which range from impairment of memory, trouble with concentration, tiredness during the day, sleep disturbance, weight gain, sexual side effects. We know that at least half of people will have sexual side effects, which include reduced libido, reduced ability to ejaculate, or experience an orgasm. There are other effects like nausea that people find disturbing, and that's sometimes the reason people want to stop their medication. Other people are concerned about the long-term health effects of the medication. So there are no long-term trials of antidepressants compared to placebo, but there are studies that find that people on antidepressants compared to people who are not on antidepressants have double the risk of cardiovascular disease, stroke, falls, and even an early death.
Now, I mean, given most psychiatric medications, or at least antidepressants, more than half are prescribed by GPs. They're not even prescribed by psychiatrists. So they might not, I assume they have, good knowledge to prescribe that, hopefully, but maybe not as deep as another specialist would. So how does a patient talk to their doctor who, especially in psychiatry, you might get labeled as non-compliant if you don't want to take your medication? How do you have that conversation with your healthcare provider?
So you're right, more than 80% of antidepressants are prescribed by GPs in Canada and America and other places around the world. I would hope that most doctors wouldn't respond with you're being non-compliant. I think there is general understanding that antidepressants may serve a purpose for people in the short term. So I think it's quite common for people to stop these medications. It's not some outrageous, exception to the rule. I think that I would hope that most GPs and psychiatrists would be able to have a conversation about the benefits and the harms and alternatives. So if a person wants to stop a medication, they'd be talking about what the adverse effects that they're experiencing are that they don't like, what benefits they think they're getting, if any, and what alternatives they have pursued or what has changed in their life. So, if someone went through a terrible period in their life after the death of a family member, things are a lot better now. Their emotions are a lot calmer. It would be completely sensible to consider a reduction or stopping medication.
What is the typical protocol for deprescribing, and what should patients look out for in terms of how they react to that process, assuming they move forward with it?
So the most common way, so let's say you were to go to your doctor, ask to stop your antidepressant. We know the most common way that antidepressants are stopped is over 4 weeks. We've surveyed patients, and we've also surveyed doctors. And that is because that's what the guidelines have said for many years. In America, the guidelines say to stop antidepressants over a few weeks, and they've said that for the last at least 10 years. Similar in Canada, they said that for at least the last 7 years. And so most doctors will probably do the following. They will halve the dose of the drug you're on for a couple of weeks, and then halve it again for another couple of weeks, and then tell you to stop it. So you may go down, say, from 20 milligrams of a drug to 10, then to 5, and then to 0. We know that causes quite a large proportion of people trouble with coming off. In particular, it causes withdrawal symptoms. We know that people's brains become accustomed to the drugs over time. You adapt to the drug. That's what causes tolerance effects and what's often described as physical dependence, which is different from addiction. It's just the process of adaptation to the drug that happens with repeated use. For example, it happens with caffeine. If we drink a cup of coffee every day, our brain becomes accustomed to it. And if we stop the drug, we experience withdrawal symptoms. And often people will experience withdrawal symptoms when they stop antidepressants very quickly over a few weeks. And those withdrawal symptoms can include both emotional symptoms and physical symptoms. And the emotional symptoms involve things like anxiety, depressed mood, trouble sleeping, panic attacks, crying spells, sometimes feeling suicidal. As you can see from the list of psychological symptoms, anxiety, depressed mood, it's very easy for people to mistake those symptoms for a return of their underlying condition. But we know that both doctors and patients are prone to do that. And so a very common story will be, doctor says, come off these drugs over a few weeks. The patient turns up, I can't sleep, I feel terrible. And the doctor says, well, you must have experienced a return of your condition. This shows you must need the medication. You better go back on it, and you might even need to use it, for the rest of your life. We now know that it's very common for people to experience withdrawal effects. We know that at least half of people will do so when they stop it. And because we know that those symptoms overlap with the symptoms of depression and anxiety, doctors and patients need to be very careful that they're not experiencing withdrawal symptoms. And so if they do, rather than concluding they must need the medication, if people experience withdrawal symptoms on stopping, it really means they need to stop the drugs more slowly. And so there's been an innovation in how antidepressants are stopped in England, which hasn't filtered out the rest of the world yet. And that involves really doing 3 things when stopping medications. 1, doing it at a rate that a patient can tolerate. So it's very hard to say there's a one size fits all. Everyone should come off over this number of weeks or months. You have to adjust the rate to what someone can tolerate. That's in the guidelines now in England. The second thing is doing it gradually. And gradually means for long-term users, that's people who've been on the drugs for more than a few months, coming off over months and sometimes more than a year and sometimes even a few years, because it can take that long for people to readapt to less drug being about. And so we know that weeks of tapering is too quick for most long-term users. And the third aspect is coming down in what's been called a hyperbolic pattern, which means going down by smaller and smaller amounts of the drug as you get to lower doses. And this is required because very small doses of antidepressants have very large effects on the brain. So rather than it being a straight line where doubling dose doubles the effect on the brain, we know that these drugs have a hyperbolic shape in terms of effect on the brain. Very small doses have very large effects, and the effects flatten out at high doses. In the meantime, what has happened is patients have worked out that doctors don't know well how to stop these drugs, and they've exited healthcare and ended up on online peer support sites to get advice on how to come off these drugs. And so, for this sort of peculiar circumstance where people are getting more helpful advice on private Facebook sites than from their doctors, there really needs to be an upskilling and increased education of doctors in Canada and America.
In the meantime, do you think are there effective peer support groups or other sort of support networks that people can rely on to deal with some of the effects of deprescribing?
Normally, the advice I'd give is go and ask an informed doctor, and that is always going to be the best port of call. It can be very hard to find such a doctor, and in the meantime, there are a variety of peer support sites that can be helpful to people. They're on, people have these groups on Facebook. There are groups like Reviving the Antidepressants and the Withdrawal Project online, and all of these places can be useful sources of education which people can bring to their doctors in order to educate their doctors, in order to get support about how to come off these drugs.
Thank you for revisiting this conversation with me on Modern Minds Rewind. You can listen, watch, and subscribe to the show on YouTube, Spotify, Apple Podcasts, and wherever else you get your podcasts. You can also stay in touch with me at Mark Henick, that's at MarkHenick, on LinkedIn, YouTube, Facebook, Instagram, and X. Until next time, I've been Mark Henick, host of the Modern Minds podcast for the Hartford Healthcare Behavioral Health Network.